I'm going to talk about PSMA imaging as a biomarker for early stage prostate cancer, so potentially a new indication for the use of PSMA imaging. And as Dave correctly said, I think we're going to see kind of an extension beyond the current approvals for for initial staging for metastatic disease and biochemical recurrence as the next few years go by. So as Dave said, the goals of imaging for localized disease, number one, and what we currently use it for is to determine if a patient has metastatic disease, but also potentially to detect and characterize the primary tumor, that is the presence or absence of cancer, particularly in patients maybe you're considering for focal therapy. Is there multifocal disease that may not be visualized or detected by MRI? What's the size and extent of the tumor? As we know, MRI underestimates tumor volume, could potentially do better. Extracapsular versus organ confined. And then in addition to that, perhaps there's actually, just like MRI provides some functional information, perhaps PSMA, because it is essentially a biological test in a sense, can it provide prognostic or predictive information as well? So the outline for the next 10 minutes, which I'll try to get through, is number one, to really talk about PSMA versus MRI. Are they additive? Does one replace the other? How should we think about this? Two, PSMA PET as a predictor of outcome. Three, PSMA as a biomarker. And then I probably won't have time for the fourth, but maybe tomorrow we could talk about it, is using PSMA as a tracer essentially for improving prostatectomy, for improving surgery using either fluorescent guidance or radio-guided surgery. So I think Isaac showed this slide the other day. This is from work from our group a few years ago, basically demonstrating the sensitivity of multiparametric MRI for detection of prostate cancer. This is looking at all disease within the prostate using whole mass, so looking at multifocality, not just index tumors. And as he showed, for Gleason 8, 9, 10 disease, it's quite sensitive, but still only about 80% of cancers are detected by MRI. For lower risk disease, that number is lower. So the question is, can we do better by adding PSMA PET? So first, just to basically set the stage, as you all know, we use the PIRAD score that was developed and has been very helpful for standardizing MRI. The group in Australia developed something called the primary score, essentially trying to replicate, in a sense, the ability to predict or level of suspicion of any lesion on a PET-CT. I don't have time to go through the details, but I would refer you to this paper published in JNM. Really good, and we and many others are using the primary score now to stage the primary tumor within the prostate. And so they then went on and conducted in Australia the primary 1 imaging trial. There's now a primary 2 study, basically asking this question about, MRI versus PSMA PET. And there are now a number of publications, including some from our own group, essentially demonstrating pretty much the same thing, which is that the sensitivity of MRI for detection of Gleason 7 and higher disease overall is about 80%. And the sensitivity of PSMA PET for detection of disease is probably a little bit higher, 90%. The question is, what's the additive value? There is some additive value, and you get 97% sensitivity for detection of lesions if you combine the two. But as you can imagine, if one is 83%, one is 90%, how much, does everybody need both? Probably not. But there's certainly circumstances in which one may add benefit to the other, as I already mentioned. This is a study from our group, which is in submission, basically trying to understand why there's sometimes discordance between MRI and PET. So we looked at a collection of about 1,700 whole mass for whom we have MRI, and a subset, about 200-300, for which we have PSMA PET. We're able basically to compare and contrast these. So the initial publication is just simply on detection and features of cancers that are detected versus not detected. One that we're looking at right now is looking at prediction of tumor volume and asking whether PET can aid our assessment of candidacy for things like focal therapy. And these are the results. And basically, pathologic tumor size and ISUP grade are predictors of concordance and non-concordance. So the larger a tumor, the higher the Gleason score, the more likely is there is to be concordance between PET and MRI. And vice versa, when there's discordance, it's usually because tumors are smaller or have lower ISUP grades. And that makes sense because we know there's a correlation in PSMA SUV with Gleason score overall. And we know that there are limits of detection both on MRI and on PET based on size. And then one question, and this is just one study also from the group in Australia. We have many cases like this too. Where should we be using PSMA PET for certain right now? And I think a typical case is somebody either who can't undergo an MRI for whatever reason. Maybe they've got two hip replacements and they have terrible claustrophobia. Perhaps they had no lesion on MRI, but you have a high degree of suspicion based on a biomarker or something else. So in a group of 45 patients with these characteristics, 25 had a lesion detected on PSMA PET, and of those, 44% had prostate cancer detected. And nowadays, you can do PET-targeted biopsies, just like we do MRI fusion biopsies. So that's aiding in detection of cases where MRI is negative, you have a high degree of suspicion. We see this commonly in cases of radiation recurrence, where MRI doesn't really show us anything. We've used PET pretty successfully to then do PET-targeted biopsies to identify sites of recurrence and prove that a negative biopsy was a false negative. So second thing I'll talk about is PSMA as a predictor of outcome. I think this is one good study, but basically just illustrates that SUV, which is obviously a measure of PSMA tracer uptake, does correlate with Gleason score and correlates with biochemical recurrence. So patients who have the highest quartile, this is a study from Australia again, patients with the highest quartile of SUVs had a higher risk of biochemical recurrence, and this was irrespective of Gleason score. So even patients with Gleason score 9 and 10, overall, those who had higher SUV had greater level of recurrence. But I think as we get into high-grade cancers, which are more poorly differentiated, this becomes a little bit muddied and is not as clear-cut as cases with lower risk disease and favorable intermediate risk disease. And then this is a study in terms of prognostic implications of PSMA PET. This was based on our prospective study at UCLA and UCSF, looking at patients who underwent surgery. And basically what this illustrates is that, so this is recurrence-free survival based on just high and low uptake. And those patients who had higher uptake had a higher risk of recurrence. Patients, of course, who had N1 disease by PSMA PET did worse. And the predictive or prognostic capability of PSMA PET prior to surgery was as good, essentially, as a Kappa S-score, that is, a Kappa risk calculator in patients after surgery. So clearly, it's adding to our ability to prognosticate and identify patients who have bad disease, and essentially gives us preoperative information that we otherwise might not get till the postoperative setting. So PSMA is a biomarker. This is some newer work that we've been working on. Adam Weiner, who was a fellow with me for the last 2 years and now is starting a position at Cedars-Sinai in Los Angeles, has been doing most of this work. And this is just a case that is, probably not terribly common, but this is a case of a guy who had very grade 5 disease. On MRI, looked like he had a large lesion. As you can see here, there's no PSMA uptake. He also has this enlarged node that also had no uptake. But this was a very poorly differentiated prostate cancer, suggesting that PSMA in some circumstances may actually reflect worse disease, which I think we know. So looking at using RNA expression data and asking what pathways are regulated by PSMA or regulate PSMA. We looked at a large number of TCGA RNA expression data. We were able to show that high PSMA expression correlates, as you can imagine, it's an androgen-responsive gene, so it correlates with androgen responsiveness, cell growth, division, and metabolism, whereas low PSMA expression actually correlated with inflammation, hypoxia, and epithelial to mesenchymal transition. So those are features, of course, of more aggressive tumors. May provide some information in terms of predicting response to things like radiation that may not work as well in a hypoxic environment. So the question is, could we or can we use PSMA as a predictive marker? Much work needs to be determined, but this is just the beginning of that work. So this shows that PSMA is highest in primary adenocarcinoma and lowest in neuroendocrine prostate cancer, again, suggesting that lineage plasticity leads to loss of PSMA as it does many other prostate-specific markers. This is a study looking at, one of many looking at outcomes of patients undergoing salvage androgen deprivation therapy, and suggesting that patients who have high PSMA expression, which correlates with activation of an androgen response pathway, may do better with androgen deprivation. So maybe could use this as a predictive marker for who should get chemotherapy versus androgen receptor deprivation. Got it, just a few more slides. PSMA low tumors were marked by multiple markers of stemness. Again, that's a measure of lineage plasticity. Many cancers, as they de-differentiate, are associated with expression of stem cell signatures, and this appears to be the case of many PSMA low tumors. And here's an example of a primary radiotherapy trial, a very high volume of patients with a Gleason grade 4 and 5, and patients who had a lower PSMA expression tended to do worse in terms of outcomes. Again, suggesting maybe PSMA might be useful for predicting response to therapies. And then maybe we'll talk about this tomorrow, but this is one example of using PSMA as a tracer for actually improving surgery. So here's a guy with a lymph node. The question is, can we successfully, without PSMA, get it? The truth is only about 50% of the time would we actually find that if we went in without any tracer. But with a tracer, such as a technetium-labeled PSMA, given prior to surgery, we can go ahead and actually detect it and remove it. So I think there's a lot of promise for PSMA in the setting of localized disease, both as a diagnostic marker, a prognostic marker, predictive marker, and potentially even as a surgical aid. And I'll end there.